Hi, Dr. Pelto here again. This is part two in the procedures that we do in the office. This is a staff training course. I'm going to talk a little bit now about carry flex. So carry flex is a procedure that we do in the office. It's used to help with detached or thickened toenails. So for example, if there's a thickened fungal toenail, it works very well for a thickened toenail. The ones that it works the best for are those toenails that only have a little bit on the base. If they only have a little bit on the base and the rest of it's not present or detached or fungal, it works really well for that. Or a nail that has a lot of they've had a previous like ingrown toenail procedure and it hasn't worked and the nail looks very narrow, so it works very well for that. The process is you first grind down the nail with one of the grinders. This is the only thing that we really grind in our practice, are the carry flex nails. You apply something called the bonding agent, which is a liquid that you put on the nail, and then you let that dry for about 30 seconds. Then you apply a coat of the carry flex. The carry flex, you apply it a light layer first, and then you do the UV light for like 30 seconds just to harden it up a little bit. And then you do it another piece. And then once you're done, then you do 2 minutes. Okay. So 2 minutes is when you do the final amount. So you tend to do a layer over then like initial layer. And then the reason you use the UV light is so it's too flexible. It moves around. It's kind of like watery-ish. And then you apply it again until you're done. And then when you're done, you cure it for 2 minutes, and then you buff the nail. Usually I buff it with there's a file that's in there to buff it down. If it's really thick, you can use the Dremel again. And then you do the sealant. There's a sealant on there. You do that and then you cure it for 2 minutes. And then the patient's all set with that. You have to remember to apply the carry flex a piece at a time and not make it too thick. And then I always say for patients, they usually come in the spring to do it unless they're going on a vacation in the winter. So if they want it in the winter, then they can come in the winter, but usually they come in the spring for it. And then it lasts about 3 months. What you'll find with the nails is that if the nail grows, if it doesn't grow out, it grows thick. And so if it grows thick, it's going to be lifted at the base of the nail. So they may come in to have it changed just because it lifts up in the back. Because a lot of these thickened toenails, instead of growing long, they'll grow thicker. Okay, so it's something that patients really enjoy and works really well for their nails. With our office, they tend to buy the kit and they keep the kit. We charge usually an increased price for the first nail and then less for the additional nails. This is an example of lunula laser. Lunula, we've had a couple of different types of lasers. In our office, we have the Cutera laser, which is the one that we typically use for warts. And we have a Remy laser, and we also have a lunula laser. So the lunula is the one that's a box, and you put your foot in the box and you turn it on. Now, if you look at these pictures, these are the nails that it works better for. So what's the difference between this and a lot of the other ones we see? These are normal thickness nails that are a little bit lytic at the end. So lytic means it's detached. Okay, see how it's detached and there's some fungus underneath the tip. But if you notice all of these nails, they're not very thick. The challenge with laser does not work very well with very, very thick nails. It works okay with these nails that are a little bit lytic or detached and have a fungus in them. So that's the main key. If you're looking at like what's the kind of the selection process for who does laser, it would be those types of patients that have less thick nails. Otherwise, we're tending to do the oral medications. The topicals aren't all that effective. So once again, works better for lytic nails. I recommend getting a nail sample prior to starting the treatment. Oral medication versus laser, you have to have that conversation with the patients. If you're wanting to prevent recurrence, there's two things that you can do. Certainly, I guess the main issue with patients I explained is that the problem is incomplete cure usually, and it's not really recurrence. Incomplete cure is because they don't take it long enough, especially like the oral medications. I like to have them until the nail is normalized. They're actually on something. So in terms of the laser, one of the challenges is if when they're using it, it's not totally grown out, there's a chance that it could regrow in. That's the incomplete cure component, but it can also come back from the fungus that can live in their shoes. So we have something called mycomist, which is a spray that can go in the shoes. We also have shoe zap, which is used to prevent recurrence, which is ultraviolet light that kills the fungus that's inside of the shoe. So if patients are concerned about the shoes, I always just say that all fungal nail treatments take 1 year to see final results because a new nail needs to grow out. I say that Lamisil is about 80% effective. Lunula is about 60% based on the nail, right? If you have these really thickened toenails, Lunula isn't going to penetrate enough. And the topical are about 20% effective. And I'll require treatment to prevent recurrence. The other thing I use for recurrence, to prevent recurrence, is I use, once they're totally better, using a topical antifungal once a week on the skin. And I do that. That would be like after it's totally gone, and that's only because many times the nail fungus can start from the skin fungus. Nail plate avulsion. This is an example of something that we do if someone has a very painful ingrown toenail, and they don't want to just take the sides out, or if they have a very thick nail, or if they have maybe blood underneath the nail, you can remove it. Here's an example of a nail that was kind of detached at the base. Sometimes these nails, they get injured at the base and they get kind of elevated, and we'll call it boggy, which is like there's drainage in there and it's kind of detached and lifted. It's almost as if someone put something underneath there and is kind of pulling it up, and it was almost lifted up. What's holding it in most likely is just the edges. So for this, we always numb it up. The only reason we wouldn't numb it up if someone is has neuropathy, but most of these patients we numb up. We don't use this type of a tourniquet. This is an old type of tourniquet for the picture I got. We usually use the little green ones that we put on the toes. And those stop the blood supply. If you didn't know, that's why we put those on there. So you roll it up on the toe, and as it rolls up, it actually pushes the blood out. And then this is the nail base. It's used for a very loose nail, also for something called a subungual hematoma, which is blood underneath the nail. It can be for a nail avulsion, which just means pulling off the nail. It can be total, meaning you take the whole nail off, or partial, which just means you just take off a side of the nail. A lot of things like the staff, sometimes you're wondering, well, what's an IND? What's an avulsion? For the staff purposes, I'll explain the difference, but an avulsion, if you take the whole thing off, is a total nail avulsion. If you take an edge out, it's a partial nail avulsion because you're doing partial of the nail. Now, if there's an infection in there, the same partial nail avulsion is called an incision and drainage. And the reason it's called, you're incising it, meaning you're cutting it, and you're draining out the infection that's usually in there. The difference is if there's redness on the side, if there's pus, things like that, that's considered an incision and drainage. The setup for the staff is all really the same. The only different setup is that if you're pulling totally the nail off, a lot of us like to use some adaptic, because this can when you pull off the bandage, it can stick. The gauze, the little fibers get stuck in there, and that's a challenge for them. And so our patients, they tend to soak before they take this off. And if you're doing a total nail, we'll do that adaptic. Apply sufficient triple antibiotic or a gauze, or use adaptic to avoid it. If the bandage sticks, soak the toe prior to removing the bandage. This is something we tell all of our patients, and we get a number of phone calls every year about that. We talked about before established patients. I'm going to talk a little bit about new patient office visits to keep it real simple. For a new patient, if they come in, it's usually a quick visit where there's no real treatment done. So no x-rays done, no nothing. They just, I had some foot pain, I want to get looked at. Maybe an evaluation of an ingrown toenail without any treatment, something like that would be a level 2. We don't do very many level 2s. We're usually doing something. Level 3 would be a more complex condition. Maybe we get imaging, which is x-rays or an ultrasound, taking a nail sample, doing a plan for the future, plantar fasciitis initial visit without a prescription. Okay, and then level 4 would be things that are more intense, surgical discussions. It's giving something that is a medication. When we talk about these levels, these are billing levels, and these are on the billing tab that we put in. But sometimes the front office staff, they need to know what level it is. Usually we'll tell you. That's just kind of a reference for us. And there's this big billing sheet. I'm not going to go into it, but it talks about like you have to, how many conditions you need and problems and what documents you're looking at. I'm going to talk a little bit about Onifix. So Onifix is different than Cariflex. So Cariflex is used for ugly toenails to cover them up. It's a cosmetic procedure. If they have a damaged nail that's never going to get better, they'll come in once a year or twice a year, and we'll do that for them. The Onifix is used for ingrown toenails, and it works better if the nail is flatter at the base. So what the base of the nail is, this part's the base. So the base of the nail right here, if it's flatter here, and then as it grows out, if it curves in, it works well. So let me give you an example. So if you look at this one, it looks like a curly Q, right? And it's flatter at the base. So if it's flatter at the base and you apply the Onifix, as it grows out, it stays on the nail. And as the nail grows, it slowly pushes out and it'll bend it'll untwist the nail at the tip. That's what it does. So you can see these examples here, a curved in one, 24 weeks later, okay, 6 months later, and then, and that's how it looks. And as it slowly grows out, and then it grows out. A lot of times we need to reapply these. I used to do it and then have people come back in 3 months. Now what I tend to do is I have them come back in when it falls off. So that might be longer period of time. If there is enough space at the when they come back, like let's say this has moved out here and there's enough room for another one, I sometimes put on 2 Onifixes. It's applied to the base of the toenail. It trains the toenail to lift out the edges at the front. Repeat it every 3 to 6 months when it falls off. If it falls off under 2 months, I apply it without any cost. So if this is something that's not covered by insurance, I usually do it for free if it falls off again, because I like to guarantee it. There's no restrictions, both with CariFlex and Onifix that we talked about before. There's really no restrictions. Patients says, well, what can I do? You can do anything you want. There's a slight chance if you're a big runner, the CariFlex and the Onifix could fall off. So if it falls off, I put it on again. I just charge an office visit, or I let them know for the office visit. And if the nail is red, infected, and painful, we do an incision and drainage. That's where you numb it up and take out the edge with anesthesia. If it's not successful, then we'll either do a partial nail avulsion or we'll do a matrixectomy. So orthotic dispensing, this is not an office visit normally. Sometimes what we do in the office is, let's say I'm seeing a patient for heel pain and they're doing orthotics. I might do a 3-week follow-up for them. So I kind of do it in a way that the orthotics I hope will become in. That's kind of how I do it. Usually it's done at the front desk, but if you set your follow-up for 3 weeks, usually the orthotics are in and you can dispense them to the patient. They can make a dispensing visit if you want, but usually that bills an office visit. So some patients are concerned about the office visits. Review shoe recommendations and make sure they're fitting well. I think that's key. Making sure they're fitting well in the shoes, making sure they know what shoes they can wear. You tend to want to do a shoe that has a sock liner that comes out. The sock liner is the thing that has the name of the shoe, and that pull that out and they put the orthotic in. A couple of modifications that we can do in the office, we can heat it up and we can drop down the arch. So if the arch is too high, we can do that. But a lot of times we can send it back with both Forward Motion and Northwest, which are the 2 labs we use. Forward Motion is a little bit easier. You don't have to send the device with it. You just kind of send back the orthotic, and it works well. And you say kind of what you want done. If you want it wider, if you want it longer, if you want the arch in a different place. It's always good to remind the patients. I know you give them the package, but it's good to let them know that there's a second pair for $200 off. And the reason we do 2 pairs is because it just increases compliance of wearing the devices. So they're going to get better results because they're wearing them more, because most people have like a workout shoe and an everyday shoe. And so they can just leave them in those. I tend to get the first pair first to make sure they're comfortable. There's no adjustments. And then I'll do the second pair as needed. PadNet or vascular testing. So this is a test that we do in the office, the staff does. Why do we do this? Because our patients, most of them are elderly or have diabetes, and those patients are at higher risk of developing PAD, which is peripheral arterial disease or clotting. The way I explain it to patients is that if you have, let's say, poor circulation to the legs, most people don't complain. Some might have what we call claudication, which is cramping in the legs. But for the most part, our patients aren't complaining. But I'll give an analogy. So if you had poor circulation to the carotid artery, which is in your neck, that could lead to a stroke. Okay. People, many times it's not diagnosed, can lead to a stroke. If you have it in your heart, it could cause a heart attack. Poor circulation, it's all the circulatory system. If you have it in your legs, it's going to create peripheral arterial disease, which many times goes silent because the patients have neuropathy, because they just think their legs are tired. And that's why we do this test. It's an easy test. It's a lot easier than checking other things, because you put these blood pressure cuffs on the legs, 3 blood pressure cuffs, and then 1 on the toe. And we do this for patients that are high risk. Okay. What was considered high risk? Diabetes is always high risk. okay, because diabetes has a higher prevalence of clogging the artery. So diabetics over the age of 50, and then non-diabetics over the age of 70. Okay. Also for patients that have ulcers to evaluate the healing potential. If it's really urgent, sometimes we send this out to the vascular lab only because we tend to schedule these, on Fridays or other days when staff is available. So we don't do them every single day. We repeat them usually yearly because we want to see if there's any changes in the circulation, and the results will come back as mild, moderate, or severe. Most of them, ours come back mild and moderate. If it's mild to moderate, we usually evaluate it. We don't. Well, we just evaluate it again. We send the results to the doctor. And then the following year, we'll see if it changes. If there's a drastic change or if they have more symptoms, then we will refer them to a circulation doctor or called a vascular surgeon. It usually takes 30 minutes to do this procedure by the staff. They have to remember to bring in shorts or they're going to put on a Johnny or something else like that. Okay, we talked a little bit about, I just kind of bunched all these together only because what I was using was the cash pay pricing kind of thing. But paronychia is different than an abscess, which is different than a cyst IND. But I just want to explain they're all kind of infections. So paronychia is an infection of an ingrown toenail. So an example of pus coming out the nail, this redness right here, you're going to either take the whole nail off or just take the edge of the nail. An abscess is an infection usually in the skin, and then you would have to numb it up and cut through it to call it an IND. And then there's also a cyst IND, which if there's a cyst, not so much a ganglion cyst, but if there's like another type of a cyst in there, that you would cut it and you would drain the fluid. So that would be, you can even, an aspiration as well. It's used for an infected ingrown toenail where you remove the painful edge or you remove the total toenail. Used to drain out the purulent abscess, or used to drain a ganglion cyst if it's not infected. We do not usually give antibiotics. This is a question that differs us than a lot of the EDs or the urgent cares, is they tend to give antibiotics for everything. Once you take out the nail, and you have them soak it, you don't usually need an antibiotic. If there is a lot of redness, you can do an antibiotic, but for a lot of our patients, we do not do antibiotics. Remy laser for pain management. We do a little bit of this, but not too much with this laser. So this has a pain setting on it. And what you do is you move it back and forth on the area of pain, kind of in a swooping motion, kind of all around it, kind of like we do a shock wave. You perform it on the pain setting. It usually takes 5 to 10 minutes. And you do 6 treatments once a week or twice a week for 3 weeks. And this can be done by staff, can be done by the doctors. It can be done in conjunction. So sometimes we're doing it in conjunction with like shockwave. You put the pain setting on and you check every 2 minutes until the pain is reduced. So the determination if it's working is if the pain when you push is working, there's no pain. Like I said, it can be done with shockwave prior to the shockwave, and your treatment is complete when the pain has reduced. So what it does is it uses the laser light to heat up and it stimulates blood flow. All these treatments that we do kind of stimulate blood flow. This one stimulates, shockwave stimulates blood flow. Talk a little bit about routine care. I just want to explain a little bit about the difference. Routine care is a kind of a difficult, challenging kind of animal in the office. Because some patients are covered, some are non-covered. I want to explain the difference. Routine care just means diabetic or non-diabetic foot care. That usually entails trimming of the nails or debriding. So the difference, trimming is when it's a thin nail, a normal nail, we call it trimming. Debriding is where we trim down or cut down the thick nails. That's debriding. And then we also trim or debride calluses. Okay, those are just technical terms that we use. We usually, in some reasons, sometimes it's covered with insurance. And why would insurance cover it? They're covering it for a patient that's considered high risk. Okay, so someone that could lead to an amputation. So not doing that care would lead to an amputation. Usually it's for thick fungal toenails that are debrided. It's covered by insurance. Normal thickness nails usually are not, unless they have what we call class findings. So class findings are something that we would document in the physical exam findings, and it usually indicates something like peripheral vascular disease, PVD, so like non-palpable pulses, diabetes with peripheral vascular disease, diabetes with neuropathy or lack of sensation. So we would check with that little Sims Weinstein, that little piece of plastic we push on their foot. And if they can't feel it, that kind of indicates neuropathy. And then different circulation, things like Raynaud's and different diseases. Regular callus trimming is usually not covered unless they have these class findings or they're high risk. So not just everyone that wants their calluses trimmed can come into the office and have the calluses trimmed. They can do it, but they just have to pay. Now, I want to explain a caveat here. There is something that is not, it's kind of a callus, but it's called a porokeratoma. Poro means pore, like a sweat gland. Keratoma is callus. So these things we see a lot of times in the office, they get confused for warts. It's a callus with a really deep core in there. And then what we do is we trim off the upper callus, we cut out the center, and then we put in one of those circular pads that we have, the felt pads with a hole in it, and then we put salicylic acid in the middle. When we do that, that's called lesion destruction. So we use lesion destruction codes similar to a wart, but the lesion destruction code is for anything that we're destroying. Usually do it one time. If you're seeing someone back like every 3 months to do porokeratomas, that might turn into routine care, right? Because usually when you're doing this, after a couple of sessions, it should resolve. Okay, so that's a kind of a high level understanding of routine care. Let's talk about strapping of ankle, foot, hammer toes, and fractures. Okay. We don't do a lot of ankle strapping, basically because of the time that it takes. Many times physical therapists will do ankle, or this is called a low-dye strapping, where you take tape and you tape it up the foot, and this gives support to the arch. What are some ways that we kind of mimic this? In the office, we do compression sleeves that kind of mimics it. We'll do an over-the-counter arch support or do an orthotic. So these all help patients that tend to have like plantar fasciitis and other types of foot pain. Okay, but we don't do a lot of strapping in the office. Fracture. If someone has a toe fracture, we do this. This is a buddy taping. So you take Coban, 1-inch Coban, tape the two toes together. You tend to tape the bigger toe to the fractured toe. You tape it to the toe that's adjacent and bigger to it. You use 1-inch Coban, and they just take it off when they shower and they put it on again, and you do that until they feel better, along with a surgical shoe or a walking boot. Okay. Then for hammer toes, there's different types of strapping. You can strap the toe down. That's for like a hammer toe, or what we call capsulitis or metatarsalgia. That's in the front of the foot. You kind of pull it down, and that's going to make it feel better temporarily. Another thing that you can use is something called a Boudin splint, which is right here. A Boudin splint kind of pulls it down. So these are considered strapping. So you could say you strapped it with this, and then you could build those things, okay, with these types of treatments. Laser scar treatment, we don't do this a ton, but for some patients that have contracted scars or thick scars or elevated scars, here's an example before and after. You can do this. I usually do 4 to 6 sessions, and in the medical record is the actual settings you put on the laser. I use the Cutera laser for this. It helps reduce stress and tension on the scar. So what I say is, when you have a scar, everything is kind of confused in the tissues, and then as you heat it up, it'll all kind of flatten out and make it a little bit more normal. Okay, and it can reduce discoloration. I use this in conjunction with like taping the skin. Putting tape on the skin reduces stress. There's silicone tape that can be used as well, and there's also cortisone injections and other things. Nail debridement, just explaining the difference. This is a debridement is considered if there's very thick nails. So if the nail is over 3 millimeters in thickness, we consider that debriding of the nail. It's different than trimming. When we bill it for 1 to 5 nails or 6+ nails. I know it's funny, but that's how we do it. And it's covered usually every 61 days. If the nail is detached or the nail bed is disappearing, what that means is, let's say this nail, if you cut this all the way back and there's only this little bit right here that's left, then you could apply that Keriflex to it to make it look good if they wanted to for the summer. Okay, this, just going back, this would not be a good candidate for laser because it's so thick, right? If you had a thinner nail, it would be. This was a better candidate for the oral medication. Okay. Nail trimming, these are just normal nails. You just trim them. They're nails that are not thick. They tend not to be ingrown. If they're ingrown, then we would use an anesthesia to numb it up. When we numb it, we would numb it at the base of the nail. Ulcer debridement. I don't want to go everything into ulcers with you, but I just want to, these are some patients we typically see in the office, like an ulcer on the 5th med head. Ulcers are graded. Most of the ulcers that we see in the office are grade 1 or grade 2. So a grade 0 is nothing. Okay, there's no ulcer, no symptoms. Um, a grade 1 ulcer is an ulcer that's superficial, meaning it's just the top of the skin, kind of like a blister. This would be a grade 1. A grade 2 ulcer is going deeper. So it would go down to the tendon or ligament. And that's, you might think, well, I'm not seeing the tendon and ligament, not in this area, but if it's right on a toe, the tendon and ligament is really close by. Grade 3, it goes down to the bone. So if it probes down to the bone or you debride the tissue down to the bone, that would be a grade 3, where you can see the bone or touch the bone. Okay. And then grade 4 is where there's a lack of circulation, which is called gangrene. And then grade 5 is really bad. We don't see that much. There are different depths of ulcers. The grade of an ulcer is how deep it goes. Like if it probes to bone, then you would call that grade 3. Okay. Or in our notes, it says it goes down to bone. It doesn't really say grades. It says it goes down to bone or things like that. Where you debride, the depth of debridement is different. So you might not debride you might not take the bone out, but you'll take the tissue lower down in there, so it's different. When it's superficial, meaning when it's closer to the top of the skin, kind of this simple one like this, we'll use Amerigel, triple antibiotics, or betadine. We would use betadine more if there's some dampness or maceration, or like it looks like dishpan hands around it. If it's fibrotic or deeper, we'll use like a collagen dressing, or like a enzymatic debrider, which there's one we use called Santal at times if it's fibrotic, and if there's drainage as well, we use this collagen. We have the collagen in our office, and you can't just do that. You have to offload it. So we'll try to put these people in offloading walking boots, that peg assist with those little pegs that you pull out, or you do felted foam. So peg assist and felted foam are very similar. Felted foam is something that you do, and that's why we like to do the peg assist, which makes it a little bit easier for taking those little plugs out. Okay. You put that in a walking boot or a post-op. And it's also good to evaluate circulation and verify that there's no bone infection with the x-rays. Okay. Ultrasound guided cortisone injection. This is something we do quite a bit. Here's the ultrasound probe. Here's the injection. This is looking at the fascia, like a normal fascia right here. This is a thickened fascia. And it's especially helpful for smaller joints, like the first MPJ, or midfoot joints, which are the joints in the middle of the foot, because they're so small. You can inject 1 to 2 cc's in each area. It's helpful for plantar fasciitis, tendons, posterior tibial tendon, peroneal tendon. These are areas that we also could do cortisone. We could also do shockwave in these areas. So I tend to use ultrasound before shockwave. And ultrasound helps find the area that's thickened. There's a dark area. It tends to be darker and thicker. And you want to document this procedure that was done in the notes and add it to the billing. And you save the ultrasound images prior to doing this. Okay. This is a limited study of the ultrasound here. This is an example that I have from a presentation. You can see these examples right here, but I tend to show like the ultrasound, what it looks like, normal and thickened, and I give some normal values for males and females. So I kind of explain this. It's the most common study in the office that looks only at the affected anatomy. You look at it in 2 angles, which is longitudinal transverse. It just means you switch the probe in 2 different angles to look at the plantar fascia, Achilles tendon, posterior tibial tendon. Make sure the images are saved. And once again, if you want to look at some of my ultrasound images, you can look here. These will be attached. This link will be attached. Ultrasound when billing an injection. If we bill a cortisone injection or aspiration, or pulling out liquid, in ultrasound, we use this category. It's less expensive than a limited ultrasound. So limited ultrasound is where I actually look, and we're billing an ultrasound, which is usually $100, or insurance covers it. If we're doing just a guided injection, we just charge $50, or we can bill it if insurance will bill it. It's just to visualize just that one area where I'm doing the injection. Uniboot is used to help if someone has venous stasis ulcers or wounds on the lower legs. Also, if they have a lot of swelling, or if they have a sprain of their foot or sprain of the ankle. It's repeated weekly by the staff if it's really bad for the ulcers. It's used to reduce ankle edema or swelling, tendonitis, foot instability. It can be used with a walking boot. You might have to take the top of the walking boot off to fit it in there. You leave it on for 3 to 5 days, and they can't shower. They would get a shower cover as well. Wart treatment, or verruca. ver- Veruca treatment. So for Verucas, there's 1 to 5, 5 to 14, 15 plus. This is the billing. Um,